a puzzling case of neurological decline and metabolic disturbance. In the bustling city of Varanasi, 48-year-old Mr. Aditya Kapoor visits the neurology clinic with his wife. She reports a concerning change in her husband's behavior and movements over the past year. Initial presentation: Mr. Kapoor presents with uncontrollable, dance-like movements of his hands and feet, progressive difficulty in maintaining balance while walking, noticeable mood swings and irritability, unexplained weight loss, despite increased appetite, recent onset of excessive thirst and frequent urination. Physical examination: the neurologist observes choriform movements, particularly in the upper limbs, mild cognitive impairment. During mental status examination, slightly slurred speech, BMI of 24.5, down from 28 a year ago. Initial differential diagnosis: 1. Huntington's disease, HD; 2. Wilson's disease; 3. Drug-induced movement disorder, spinocerebellar ataxia; early onset Parkinson's disease with atypical features. Points in favor and against each diagnosis: 1. Huntington's disease. 4. Choriform movements, cognitive and behavioral changes, age of onset, consistent with HD. Against: no reported family history, yet to be confirmed. Metabolic symptoms: thirst, frequent urination, not typical of HD2. Wilson's disease for Mickey: movement disorder and behavioral changes, potential for metabolic disturbances. Against: typically presents earlier in life, absence of hepatic or ocular symptoms. Drug-induced movement disorder for May can cause choriform movements. Against: no history of neuroleptic use or other relevant medications, progressive nature of symptoms. Spinocerebellar ataxia for Pesci: Sampali pass progressive nature of symptoms, balance. Difficulties. Against: choriform movements more prominent than ataxia, cognitive symptoms not typical in early stages. Early onset Parkinson's disease with atypical features. For movement disorder and cognitive changes. Against: lack of typical Parkinsonian features, rigidity, bradykinesia, choriform rather than tremor predominant movements. Stepwise investigations: 1. Basic blood tests, complete blood count, liver function tests, fasting blood glucose and HbA1c thyroid function tests. 2. Neuroimaging, MRI of the brain. 3. Genetic testing, HD genetic test, CAG repeat analysis. 4. Copper studies, serum ceruloplasmin, 24-hour urinary copper excretion, neuropsychological evaluation, oral glucose tolerance test, OGTT, results and final diagnosis. The investigations reveal HbA1c of 7.2% and abnormal OGTT, consistent with type 2 diabetes mellitus, T2DM. MRI showing mild atrophy of the caudate nucleus and putamen. Positive genetic test for HD with 43 CAG repeats. Normal copper studies. Based on these findings, Mr. Kapoor is diagnosed with both Huntington's disease and type 2 diabetes mellitus. Explanation of the interconnection: the co-occurrence of HD and T2DM in Mr. Kapoor's case is not merely coincidental. Recent research has shown a complex interplay between these two conditions. 1. Insulin resistance. HD patients often exhibit insulin resistance even before the onset of motor symptoms. This predisposes them to developing T2DM. 2. Mitochondrial dysfunction. Both HD and T2DM involve mitochondrial dysfunction, which may exacerbate cellular energy deficits in affected tissues. 3. Hypothalamic dysfunction. HD affects the hypothalamus, which plays a crucial role in metabolism and glucose regulation. This may contribute to the development of TUDM. Shared genetic risk. Some studies suggest that the HD gene may influence glucose metabolism, potentially increasing the risk of T2DM. Weight loss paradox. Despite weight loss being common in HT, which typically reduces T to DM risk, the metabolic disturbances in HT can still lead to diabetes. Treatment plan 1. For Huntington's disease, tetrabenazine for chorea management, cognitive behavioral therapy for mood symptoms, physical and occupational therapy 2. For type 2 diabetes, metformin as first line treatment. Dietary modifications and exercise plan tailored to HD symptoms. Regular glucose monitoring 3. Multidisciplinary approach. Regular follow ups with neurology and endocrinology, genetic counseling for family members, nutritional support to manage weight loss and diabetes. Conclusion. This case highlights the intricate relationship between neurodegenerative disorders like Huntington's disease and metabolic conditions such as type 2 diabetes mellitus. It underscores the importance of comprehensive evaluation and multidisciplinary care in managing patients with complex neurological and metabolic presentations. The co-occurrence of these conditions presents unique challenges in treatment and emphasizes need for personalized judgment strategies. Key references 1. Farrell, Diabetes mellitus in Huntington disease, ClinGenet, 1985 to 7 C267, Montojo M.T. Aganzo M. Gonzalez N. Huntington's disease and diabetes, chronological sequence of its association. J. Huntington's Days, 2017, 6-3, 79, 88, Hurlbert M.S., Joe Dovis Meyer C. et al. Mice transgenic for an expanded CAG repeat. In the Huntington's disease gene developed diabetes 1999.B3 649 651.